Good morning. I call the Human Services Policy and Finance Committee to order. Members, we have a quorum present. Representative Norris, did you have a time to look at the minutes?
Yes, Chair Noor. I move adoption of the February 25th meeting minutes.
Representative Norris moves the adoption or approval of the minutes for February 25th, 2026. Any discussion? Hearing none. All those in favor, please say aye. Aye. Opposed? The minutes for February 25th, 2026 are now approved. Members, we have a couple of bills today, but we've got a technical issue which we're hoping to solve as soon as possible. We're waiting for the amendments, but I think we can get started. So we will start with House File 3423. Representative Hicks.
Good morning, chairs and committee.
Good morning. Please move your bill and proceed with your testimony.
Okay, so the bill in front of you does have an amendment that we are awaiting on for you to be able to see. So just wanting to make sure you see that as we get that printed. The amendment does some things that cleans up some language and also makes sure that this works in a variety of different ways, expanding, like, for example, one of the things that the amendment does is instead of talking about cash on hand, it talks about financial stability, for example, because it may not, it may look a little bit different. When you see the amendment, you can see some of the changes. The heart of this bill is really to tighten up enrollment, making sure that enrollment is done in a way that ensures that we are getting providers who are comfortable with doing the service, but who can do the service and can demonstrate that they can do the service. I think one of the things that I learned during this prepayment review and pause is that when providers were not financially secure, it was our clients and our workers who suffered. People didn't get paid, or people didn't get cared for. Both of those things were bad for the folks who are most vulnerable. And so this bill works to make sure that our providers can do those things consistently. I am happy to go through the different portions. I do wish we had the amendment in front of us because it does, change quite a few things. I do want to thank Chair Noor and Chair Schumacher for sitting down with me and their teams to go through and talk through the things that they also saw as important, so we could work collaboratively to make sure we put forth the best bill for individuals to get the services they need and to protect workers, individuals, and Minnesota taxpayers. So, Chair Noor, would it make sense to just open up to questions while we wait for the amendment, or do we need to move the amendment? I'm sorry, I'm not sure what to do in this situation.
Thank you so much. Representative Hicks moves House File 3423 to be laid over for possible inclusion. With that, I wanted to ask if nonpartisan can just walk us over the House research, and we will wait for the DE for adoption. Representative Beck.
Yeah, it's just a suggestion. Is there that many changes, or could we just do it orally?
It's many changes.
Okay, very good.
We had almost an entire team working over the changes. We've got a similar bill introduced by Chair Schumacher and also
just wanted to know.
So it's a DE.
Okay, very good.
Please introduce yourself and proceed.
Thank you, Mr. Chair. I'm Annie Mock with House Research. So I'm going to walk through the DE1, House File 3423. And just to sort of set the table here, there are two buckets of changes in this DE1. One are the changes that Representative Hicks requested that are made to how providers get enrolled into MA. But the other set of changes is related to recodification of current statutes. So under current statutes, all of the changes or all of the requirements governing provider enrollment are in one small subdivision. And so what this DE1 does is sort of pulls those out of their current place and puts them into new sections to make it a little bit easier to follow the requirements. So you'll see both sets of changes in this DE1. So the first 3 sections of the DE1 are all just technical changes, updating cross-references related to that recodification I mentioned. Section 4 of the DE1 requires that DHS include in its annual report on MA information about all of the sort of site visits it conducted, pre-enrollment, post-enrollment, and unannounced site visits in the previous fiscal year. This is all new language that's being added in the DE1. Section 5 is where you'll see the recodification. So Section 5 is in current statutes, is where all of the provider enrollment requirements are. And you'll see that all of those requirements get moved under the DE1. So then Section 6 is all about provider enrollment. It creates a new section of statutes. The first subdivision designates categorical risk levels. You've probably heard about these risk levels where provider types have to be categorized as either limited, moderate, or high risk. So this language is largely just a recodification of current statute with some technical modifications. Subdivision 2 adds a number of different verifications and checks that the commissioner will have to do when enrolling providers into MA. A lot of these verifications and checks are in federal regulations, so the state currently has to comply with them, but we're now adding them to state statutes. Subdivision 3 has to do with background studies. It requires the commissioner to conduct background studies for all providers applying to enroll in MA, and also requires background studies for a number of individuals who are employed by the provider. So those are any individuals with an ownership or control interest in, or who's an officer, director, agent, or managing employee of the provider. The section also provides, or the subdivision, excuse me, also provides that fingerprint-based background studies are required when mandated by federal law or when a provider is designated as moderate risk or high risk. And the section, or the subdivision, also allows the commissioner to conduct post-enrollment background studies as necessary. A lot of this language is, again, recodification of current language, but with some substantive modifications. Subdivision 4 has to do, or requires that providers enroll each provider-controlled location where they're providing direct services into the program, and also provides a few exceptions for certain types of locations. Again, this is largely a recodification of what's in current statutes. Subdivision 5 has to do with site visits. It requires that providers allow CMS and DHS to conduct unannounced site visits at any of the provider's MA-enrolled location. And it also directs the commissioner to conduct certain site visits. So for each MA provider that is considered moderate or high risk, the commissioner will have to do pre-enrollment and post-enrollment site visits. And then for all providers, the commissioner will conduct unannounced site visits at certain time periods. And this is largely, again, a recodification of what's in current statutes with some modifications, particularly around those unannounced site visits. Subdivision 6 requires that a provider purchase a surety bond as a condition of enrollment in MA. This language is largely, again, recodification of current law, except that under this language in the DE1, the purchase of a surety bond is required in certain circumstances rather than something that the commissioner may require. Subdivision 7 has to do with the financial capacity that Representative Hicks mentioned. It requires a provider to demonstrate sufficient financial capacity as specified in order to enroll in MA. This is new language. Subdivision 8 has to do with compliance programs. It allows the commissioner to require, as a condition of enrollment in MA, that an MA provider establish a compliance program. And then it specifies that the provider has to designate someone to be the compliance officer and specifies what duties that person has to carry out. This is largely just a recodification of what's in current statutes with a few small substantive modifications and a few technical modifications. Subdivision 9 has to do with incomplete provider enrollment applications. It directs the commissioner to deny a provider's application in certain circumstances. This is a recodification of what's in current law. And subdivision 10 requires the commissioner to deliver correspondence and notification other than those involved with background studies directly electronically to a provider. And this is just a slight change from current statute, making that electronic notification a requirement rather than permissive. Moving on to section 7, this has to do with when providers are revalidated to continue enrollment in MA. Subdivision 1 just is technical language providing that the commissioner must revalidate each MA provider according to this section. Subdivision 2 lays out the schedule for how, when the commissioner has to revalidate providers. This is largely a recodification of what's in current law with a change to provide that when a provider is designated high risk, that revalidation needs to occur every 3 years rather than at the discretion of the commissioner. And then subdivision 3 provides the procedures that the commissioner needs to follow when, revalidating the providers. This is again largely a recodification of what's in current statute, although it does add that revalidation must include unannounced site visits at each of a provider's enrolled locations as part of revalidation. And it also provides that financial capacity that the provider has to demonstrate upon enrollment, they also have to demonstrate at revalidation. Subdivision 8 has to do with when providers can be suspended and terminated. So subdivision 1 this is section 8, apologize for that. But section 8, subdivision 1, requires that the commissioner suspend a provider's ability to bill if the provider is not in compliance with program requirements. It also provides that suspension has to be in place until the provider comes into compliance. Subdivision 2 allows the commissioner to revoke a provider's enrollment if the provider fails to maintain and provide the commissioners access to certain types of documentation that are specified there. And this is largely just a recodification of what's in current statute. Subdivision 3 adds new language to state statute it's largely federal requirements governing when the commissioner must terminate or deny a provider's enrollment in MA. So that's in paragraph A. It's a very long paragraph, but again, a lot of the information in that paragraph is currently in federal regulations and it's just being added to state statutes. And then paragraph B allows the commissioner to exempt a rehabilitation agency from certain types of termination or denial in certain circumstances. And this is just a recodification of what's in current statutes. Section 9 provides that it gives the commissioner the authority to withhold payments for a 90-day period if a provider upon enrollment is in one of those high-risk categories. And this is just a recodification of what's in current statute. Section 10 is all new language in section 10. Subdivision 1 allows the commissioner to issue a statewide or regional provider enrollment moratorium for up to 24 months for any provider type that is designated as high risk. And it also directs the commissioner to revalidate the enrollment of each provider that's subject to that moratorium before the moratorium ends. Subdivision 2 provides that for any provider that's subject to that moratorium that's already enrolled in MA, they can continue to enroll new clients and beneficiaries. Subdivision 3 is a notice requirement directing the commissioner to issue notices to enrolled providers and the legislature at least 10 days prior to implementing an enrollment moratorium. And then subdivision 4 directs the commissioner to submit a report to the legislature about that moratorium within 60 days of ending it. Section 11 has to do with specific enrollment requirements for providers or suppliers of durable medical equipment. This is all a recodification of what's in current statute. And then subdivisions 2 and 3 have to do with requirements for providers that are licensed by the Commissioner of Human Services under 245A or licensed by the Commissioner of Health. Again, this is all just a recodification of current statute with a few technical modifications. Subdivisions 12 through 14 are all technical. They're updating cross-references having to do with the recodification. And then section 15 is new language that directs the commissioner to amend Minnesota rules to update the definition of fraud with the correct citation to a federal law. And that is the DE1.
Thank you so much, Ms. Mack, for the overview of the DE1, and we have testifier online, so we'll get going with the testimony from the online testifier. Please introduce yourself for the record and proceed with your testimony.
Hello. Thank you, Chair and members of the committee. My name is Joel Bakken, and I serve as Executive Director of Solutions Behavioral Healthcare Professionals, a nonprofit community mental health center serving East Grand Forks, Moorhead, Detroit Lakes, Fergus Falls, Alexandria, and St. Cloud. For more than 26 years, we have provided a comprehensive continuum of community-based mental health services. We were also among the first providers to deliver EIDBI when the benefit was launched in 2014. Solutions is accredited by the American Psychological Association and the Behavioral Health Center of Excellence. Those accreditations required rigorous review of our clinical services, billing practices, governance, and compliance systems. We opened every aspect of our organization to independent scrutiny, and when Minnesota DHS contracted with Optum last year, we voluntarily underwent an additional national compliance audit to ensure we met every mental health and EIDBI standard. We took that extra step because of Solutions' challenging and burdensome history with Optum. HF 3423 requires current EIDBI providers to maintain a 90 days of payroll reserves to pass revalidation. That requirement assumes EIDBI organizations are operating with substantial margins. We are not. We operate on tight budgets and reinvest in staff training, clinical supervision, and high-quality programming for these children. The bill also requires a surety bond, but a surety bond does not prevent fraud. If this legislation is focused on strong fiscal responsibility and meaningful oversight for MA providers, I stand with you. What I cannot accept is the idea that credible EIDBI providers must bear the burden of fixing DHS's fraud problem. Solutions does not rip off the state. Our clinicians and behavioral staff show up every day with professionalism, compassion, and deep commitment. We provide these services with integrity. Minnesota absolutely must prevent fraud, but if the data being publicized is inaccurate or lacks context, we cannot clearly define the problem, let alone solve it. Suggesting that 90% of claims are flagged without clear explanation risks equating flags with fraud or abuse. Inaccurate reporting creates confusion, damages trust, and destabilizes a system families rely on. Let's pursue excellence. Let's pursue accountability grounded in accurate and transparent information. And let's ensure that oversight strengthens rather than undermines access to high-quality care for Minnesota's children. Thank you.
Thank you so much, Mr. Becken, for your testimony. We have two more testifiers here, Ms. Donahue and Mr. Skelton. If you can proceed to the testifier table and begin your testimony. Please introduce yourself for the record and proceed.
Chair Noor and the members of the committee, thank you for allowing me to testify. My name is Sandra Bond. I got married, so it used to be Donahue. President of the Marsh, Minnesota Association of Residential Service Homes. I am testifying on behalf of our membership, which represents adult foster care and community-based residential service providers across Minnesota. Marsh must respectfully oppose HF 3423 as currently drafted. While we support strong program integrity standards and responsible stewardship of medical assistant funds, The bill expands provider enrollment requirements at a time when residential providers are already facing significant financial strain due to Minnesota's transition to a flat rate reimbursement system. The combined effect of expanded regulatory requirements and reduced reimbursement flexibility creates a structural mismatch that threatens the stability of small, community-based providers. Under prior rate methodologies, administrative and compliant costs were recognized within rate calculations tied to service needs and operational realities. Under the current flat rate structure, providers received a fixed reimbursement regardless of resident acuity, administrative burden, or compliance expansions. The bill proposes enhanced enrollment standards, expanded screening obligations, possible compliance officer requirements, and increased documentation and revalidation expectations. These requirements carry real administrative and financial costs. As a result, provider must divert already limited direct care dollars to new compliance infrastructure. For small adult foster care homes operating on narrow margins, there is no ability to absorb these additional obligations without impacting staffing, wages, or care quality. Marsh represents many small family adult foster care homes serving 1 to 4 residents. These providers are not large healthcare systems with compliance departments. The owner is often the caregiver, administrator, scheduler, and payroll processor. HF 3423 applies expanded enrollment and compliance expectations uniformly across provider types without differentiation. For small 245A licensed residential providers, the bill risks imposing corporate-level compliance standards on home-based operations that lack administrative scale. Under a flat rate system, small providers cannot spread compliance costs across multiple sites or revenue streams. This creates an uneven burden that will disproportionately affect precisely the community-based Minnesota settings Minnesota has historically sought to preserve. Minnesota is already experiencing adult foster care closures, workforce shortages, and recruitment challenges. Adding new enrollment hurdles and compliance risks without corresponding reimbursement adjustments may accelerate provider exits. When a residential provider loses enrollment or cannot economically comply, residents do not simply lose paperwork, they lose their homes. Displacement of vulnerable adults due to administrative strain undermines the very goals of a medical assistance oversight. This bill, when combined with flat rate reimbursement, increases the likelihood of provider attrition, consolidation into larger corporate entities, reduced access to small community-based services, and service disruptions for vulnerable adults. If the legislature expands regulatory requirements, it must ensure that reimbursement systems reflect these obligations. Implementing enhanced compliance structures in a flat rate environment effectively creates an unfunded mandate. Marsh is not arguing against accountability. We are raising concern about timing and structural alignment. Expanding enrollment and oversight requirements during a period of rate compression risks destabilizing an already fragile network. Marsh urges the committee to pause or amend HF 3423 until its fiscal and operational impact on flat rate residential providers can be evaluated. Thank you for your consideration.
Thank you so much for your testimony. Ms. Skelton, please introduce yourself for the record and proceed.
Chair Noor, Representative Hicks. My name is Ellie Skelton. I'm the Executive Director at Touchstone Mental Health. And it sounds like the 90-day payroll thing might be fixed in the amendment, so that shrinks my testimony to 45 seconds. So that's good. I appreciate her willingness to work on enhancing program integrity. I'm the Executive Director of Touchstone Mental Health. I said that, I think so. Okay, the two areas that I have some concerns with is the surety bond language, the $100,000 or 10% of Medicaid billing. If we could look at that threshold, we hold a lot of insurance already, professional liability, umbrella insurance, employee dishonesty, cyber liability insurance. Insurance costs have been skyrocketing. Luckily, cyber liability hasn't been continuing to escalate so high, but adding an additional, I would just suggest, could we look at lowering that percentage? We provide 98% of who we serve as low-income Minnesotans with serious mental illness, mostly Medicaid or PMAP billing. So if we could just look at that, maybe not 10% of your Medicaid payments. We operate basically a break-even business. So every additional cost It's just, it comes from staffing. And so, I don't want to lay off staff or reduce staffing. The other one I wanted to talk about was the moratorium language, new settings for existing providers. I just wanted to make sure that with respect to section 16, that their clarification would be helpful to ensure that new settings or new locations for existing providers are allowed. As an example, Touchstone Mental Health has been working with Aon, a nonprofit housing developer, for 10 years on a housing project downtown. Luckily, 72 new units of beautiful, affordable housing will open in December of this year. If a moratorium unintentionally delayed or prevented long-planned projects like this from moving forward, that would be an unintended consequence. I just want to make sure that language is really clear that projects, especially in outstate Minnesota, sometimes it takes 3-4 years to get a project up and running, so that existing providers can add new settings and locations. I would just like to make sure that that's super clear, because sometimes it's the ambiguity of the moratorium and who it exactly applies to. I think that's all I have. Thank you for the opportunity to testify.
Thank you so much for your testimony. We have the DE before us, so we've already walked through. Representative Hicks moves the adoption of DE1. Any discussions? All those in favor, please say aye. Aye. Opposed? The amendment is now adopted. To your bill as amended, final words probably, and then maybe discussion from members.
Yes, thank you so much. I appreciate everyone's testimony and their concerns. I understand that there are concerns around increasing oversight and regulation because it may increase cost. What I will say is that I'm open to more discussion, but we're sort of here because we keep doing that. I have watched as a parent and then as a legislator, anytime additional oversight or concerns are brought up, particularly around things that protect people and staff, the pushback from providers is always around the cost. And we as legislators hear that and want to respond and make that better, and so we adjust, and we end up here. This is how we got here. I would point out to you that in front of you today and in front of your testimony is not a single person who receives services. And I would remind you that in this committee, that is frequently the case. This bill is about protecting the people who receive services and taxpayers. And again, I would point out, there's not a single person who receives services here today. And I would challenge you all to think about how often you sit around this ring, and that is the case. If we are making changes to statute to protect people, we need to be centering people first and then making sure that we make the program work. And I think we can do that. I think there's absolutely room to have those conversations, but we have to start having them. And that is a hard thing to do. So thank you for your time.
Thank you so much, Representative Hicks. Mr. Chair, Chair Schumer.
Thank you, Mr. Chair, and thank you, Representative Hicks, for this, and thank you for the process that we've started on this one. Instead of having dueling bills and dueling hearings on very similar concepts, it was good to try and select one to have a path going forward. And I would just note that, at least from my intention, it wasn't the final word on this. We just wanted to have that path. And the feedback I've been getting already since the DE's been posted is a lot of it's technical, some of it's the policy piece, but a lot of it is technical that we can work to clean up. And so I'm glad to see that we're going to lay this over so we can continue working on it, and we will continue working on this. And one note from the testimony to point out is on the section 10 piece on page 16 that it's permissive language for the enrollment moratorium piece in there as we have it now. And I just wanted to make that clear on the record for that. And thank you again for your work on this.
Thank you, Chair Schumer. I think this is the work that we do, and I wanted to appreciate the nonpartisan staff for their effort to get us here. This is more about pre-enrollment, post-enrollment, and also ongoing process. I know there are two sections which are not included in this bill that we promised that Chair Schumacher will get to. the prepayment review process, and also payment withhold. So those are two sections we're going to take a deep dive also. So this is a comprehensive bill. Representative Gandhi.
Thank you, Mr. Chair. Just one question. Maybe it's clear to everyone in the room but me, but I'm looking at the 12.6 and payroll for 90 days. To meet that requirement, would I need to have cash on hand, or would a standing line of credit available at the bank be sufficient?
Yes.
Representative Hicks.
Thank you, Chair. Yes, that was the change in the amendment because someone was like, we don't have cash. And I was like, valid. A line of credit is completely acceptable with the way that this language is written. The intent here is that if your payments are withheld for 90 days, you can pay your staff. The goal is to make sure that we don't have what we've seen, which is providers who did not have a line of credit, did not have cash, did not have opportunity. And so people lost services and people lost their jobs. And in some cases, I have heard from direct support workers who were not paid for 2 or 3 weeks worth of work because their business just closed and they never got compensated for the work they provided.
Representative Gandhi.
Thank you, Mr. Chair. Nobody in this room likes a lot of regulation. You know, heavy top-down regulation from government is not a good thing. But we saw a vulnerability when we had that little payment lag. We saw a vulnerability that opened up for a lot of our people that receive these services, right? If that provider would go away for a 1 or 2 week lag in payment, we realized that was a vulnerability, and we do have a duty as policymakers to try to close that vulnerability. So I applaud your effort. Thank you.
And also that includes account receivable in that instance where they're waiting to be paid, so that will be counted. Vice Chair Gilman.
Thank you, Chair. And I just wanted to just make a quick comment. Thank you, Representative Hicks, for continued conversations in the interim as we've talked through a lot of these issues. I do want to note, I really do like the report to the legislature. I'm curious if in other parts of statute, maybe nonpartisan could say this, but the line in 16.32 where it talks about the commissioner must submit a report to the chairs and ranking minority members of the legislature committees. So I love that you would have a report come back to us within 60 days, no matter who's in sitting at the gavel. I appreciate that because that creates more transparency, and it's exciting to see that. So thank you.
Thank you so much. Briefly, Representative Hicks.
Okay, I want to give credit where credit is due. That was Chair Schumacher's idea.
With that, Representative Hicks renews her bill, that House File 3423, to be laid as amended, to be laid over for possible inclusion. We now move on to the next bill, Representative Norris. And I see we're honored to have Attorney General Ellison. Welcome back to the People's House. Yeah, we'll just go ask the team to talk about it. Good morning. Welcome again. And Representative Norris, please move your bill. We will wait for the A5 amendment as it's coming down right now, so we will get started.
Great. Thank you, Chair Noor and members of the committee. Like so many Minnesotans, I am furious about fraud. And it's why I introduced this bill last year to beef up the Medicaid Fraud Control Unit. This bill has bipartisan support, and it passed out of the House last year. Unfortunately, it got stuck in the other body. So we're back today with an updated bill, hoping to get it passed into law to meet the moment for Minnesotans. Medical assistance fraud steals from hardworking taxpayers across Minnesota. It also steals money meant to provide health care to low-income Minnesotans. That's disgraceful, and we're here to crack down on that type of fraud. This bill does what Minnesotans expect us to do: enhance our ability to investigate fraud and stiffen penalties for those who steal from government programs. The bill, as amended, would add 18 new staff members, including 11 new investigators and 3 attorneys, to the unit to match the growth in Medicaid spending and fraud claims. It also expands the definition of Medicaid fraud to keep up with our evolving understanding of the schemes to defraud the government as part of the business model of fraud. It establishes new tiers of penalties for medical assistance fraud over $100,000 and $1 million. It brings medical assistance fraud prison time in line with other theft laws. It allows us to better prosecute long-running and sprawling fraud schemes by adjusting the statute of limitations and including medical assistance fraud in the state racketeering law. And lastly, we expand the Attorney General's subpoena authority so it can get access to the same financial records that county attorneys are able to access. This office is already doing meaningful work. The Medicaid Fraud Control Unit from 2019 to 2025 secured over $80 million in civil penalties and criminal restitution. And compared to Medicaid fraud units in similarly sized states, Minnesota has won the most convictions. Importantly, members, in tough budget times, there is a 3-to-1 match from the federal government for the state dollars that we contribute to the Medicaid Fraud Control Unit. So this is a good, responsible use of state dollars to fight fraud. Simply put, this bill supports the work of catching people who steal from medical assistance and make sure that they are held accountable. Thank you, Chair Noor.
Thank you so much, Representative Norris. And since we don't have the amendment, I just wanted to make sure that you move your bill. Representative Norris moves House File 2354 to be re-referred to Judiciary, Finance, Civil Law Committee. So with that, we'd like to welcome Attorney General Ellison. Welcome, and please introduce yourself and proceed with testimony.
Certainly a pleasure to be with you, Chairman Noor, Chair Schumacher, and all members. Thank you very much. I'm pleased to be joined by Representative Norris and also Nicholas Wonka, who is the director of the Medicaid Fraud Control Unit in my office. He is the hands-on, on-the-ground one who leads a group of prosecutors and investigators who do this work every single day, and I hope you'll entertain some of his thoughts as well. So when people commit Medicaid fraud, they're stealing from the most vulnerable neighbors, they're stealing from honest care providers, and they're stealing from the government. It is the job of my office and the federal government to hold Medicaid fraudsters accountable. Across the country, AG offices house what are called Medicaid fraud control units. Every state has one, and they are in part funded by the federal government and by state governments. Now, even though we're not the exception among the states in having control units, we are exceptional in having one of the most effective units in the country. Since I was sworn in as AG of the state of Minnesota, we've won more than 300 convictions in Medicaid fraud and won more than $80 million in judgments and restitution for Minnesota taxpayers. This is a highly specialized team of people who are good at what they do. So good that the federal government itself has recognized that our MFCU, Mafuku is what we call it, has won more convictions than any other state with a comparable Medicaid budget. So while we're proud of the work, we don't want to rest on our laurels. Last year, Last year I was proud to partner with Matt Norris and Senator Ann Johnson to introduce the Bipartisan Medical Assistance Protection Act, or MAP Act, to provide more resources and tools for fighting Medicaid fraud. This year, we're amending the bill to add even more resources and add more tools to fight Medicaid fraud, because the moment we're in calls for us to do more. First, let me review the additional resources we're asking for. The MAP Act adds 18 dedicated specialized staff to our Medicaid Fraud Control Unit, bringing the total number of staff from 32 to 50. It's very important to make clear that the federal government matches every dollar we dedicate to fighting Medicaid fraud on a 3-to-1 basis. For every dollar Minnesota puts in, the feds put in 3. So 18 new staff might sound like a lot, but Minnesota only needs to pay a quarter of that. Buy one, get 3 free. This means that we can add 18 additional fraud fighting staff for only $1.2 million per year. Here's why this is important. When the unit's staffing level was last set at 32, Minnesota's total Medicaid budget was about 13 billion. Now it's 20 billion, and that's more than 50% higher, yet our staff is what it was. The referrals that the unit receives from state agencies and managed care organizations are on track to triple this year over the last year. The recommendation for 18 staffs comes directly from the Federal Department of Health and Human Services. In their last analysis of the unit, they recommended that we reach the staffing level by 2028. Yes, we know it's 2026, but the level of staffing will help us meet Minnesotans' expectations now. And as you know, the State Director of Program Integrity, Tim O'Malley, recommended just 2 days ago, maybe 3 days ago now, that the fraud-fighting resources be expanded to our office. Now, I'd like to talk about some of the improved legal tools that we're asking for, and Mr. Wonka will elaborate a little bit. The MAP Act 2.0 will close some legal loopholes that have allowed some fraudsters to avoid accountability. Right now, Minnesota law defines Medicaid fraud as presenting a false claim for reimbursement with intent to defraud. That's it. Such a narrow definition is challenging for prosecutors because it does not capture all of the morally repugnant and criminal conduct that can be part of Medicaid fraud. The MAP Act updates the definition of Medicaid fraud to clearly ban things like lying with the intent to defraud while enrolling as a false provider, falsifying records about delivery of services, or destroying records when you receive a request for those records from a state agency. These things, I believe, are now illegal and constitute Medicaid fraud, but there have been courts who have raised questions. A more improved definition will put these convictions on more solid ground. The MAP Act will equalize penalties for fraud. And when I say equalize, I just mean equalize. They won't make them more severe than other types of fraud. They'll equalize them. They'll bring them up too, so that it won't be more advantageous to steal from the government than a private sector party. Right now, if you defraud Medicaid of 36 million, you're subject to the same penalty as if you defrauded it for 36,000. This is because of a law that hasn't been updated in decades. And our bill creates new penalties for Medicaid fraud over $100,000 and over $1 million. And yes, we do have claims that high. Right now, Medicaid fraud is attractive for scammers because the current penalties for stealing from a private entity are higher than stealing from the government, and we should all fix that. The MAP Act adds more legal tools to help investigate and prosecute major fraud schemes, like adding Medicaid fraud to our racketeering laws, giving our office the ability to subpoena financial records that we now have to go through a county attorney for, and expanding a statute of limitations so that we can better go after long-term fraud schemes conducted over years. The role of the Attorney General's office in fighting Medicaid fraud is investigating and prosecuting individuals when state agencies or managed care organizations refer their cases to us. We're not on the front end. We're on the back end. The front end is screening and is screening the good and the bad providers or whoever. The middle slot is monitoring people. We are at the point where the 911 call is made, and we then determine probable cause and then charge the case and prosecute it if it exists. So let me just say, members, it would be great to have bipartisan support on this very important bill, and we thank you for your questions. And I humbly ask the chair for time for Mr. Wonka to present.
Dr. Wonka.
Yes. Chair Noor, Chair Schumacher, members of the committee, thank you for the introduction, Attorney General. I'm Nick Wonka. I'm the Director of the Medicaid Fraud Control Unit, and I'd like to just elaborate on a couple points that the Attorney General made. First, I'd like to add more context for our request for higher staffing. In 2019, when we went up to 32 full-time staff, we had 144 unique referrals that year from DHS, from law enforcement, from the public. We've been well over 200 referrals in each of the past few years. This is a more than 40% increase in referrals with no additional people to take on the work. And the cases that we're getting are only more complex. They often now contain networks of providers or owners of multiple agencies who are all separately defrauding the Medicaid program. And we need to investigate and prosecute people for each and every one of those instances. These cases take many more resources to investigate. A healthcare agency with hundreds of employees, hundreds of clients, is a lot more investigative resources than a single home care worker who's defrauding the program, as you can imagine. And as Attorney General Ellison noted, referrals this year are up dramatically. Just to put a finer point on it, last federal fiscal year, we got 218 separate referrals. This federal fiscal year started on October 1st of 2025, so we're a little over 4 months in. We are already over 200 referrals from DHS, from managed care organizations, from the public, from other law enforcement entities. But that increased work hasn't stopped us from getting results. Even though Minnesota's Medicaid fraud unit does not have a top 10 staff size, we're in the middle of all states. We punch above our weight. Last year, we ranked 6th in investigations per Medicaid expenditure, 5th in fraud charges, and 8th in fraud convictions in the entire country. Further, we're on average 5th in fraud convictions in the entire country over the last 6 years. That's a long-running track record of success for our unit when compared to other states. I'd also like to provide a little more context on the policy changes we're asking for. Now, an important reason we're asking to amend the medical assistance fraud statute to cover current gaps in it is because district courts read the statute inconsistently. Some courts read it expansively to include the fraudulent conduct that law does not specifically name, some of the things that the Attorney General touched on. But some other courts have dismissed cases of ours because the conduct we allege did not match up word for word with either the theft by false representation statute or the theft by swindle statute or the medical assistance fraud statute. Amending the law in the way that we are asking for here to name many different types of fraudulent behavior we are uncovering in our investigations should fix this inconsistency and allow for more uniform justice throughout the state. And as Attorney General Ellison mentioned, we are also asking for subpoena power that county attorneys already have when they conduct criminal investigations. The revision would allow us to subpoena financial records in provider fraud investigations, which we do, and are conducted under Minnesota Statute 256B12. County attorneys have the authority to do this when they're investigating welfare fraud, so fraud for recipients who are inflating their income, their resources, or something like that to obtain benefits. We ask for the same authority when we conduct provider and fraud investigations. In giving us this authority to subpoena these bank records that county attorneys can is consistent with ensuring accountability for all fraudsters throughout the state of Minnesota, no matter what programs they're stealing from. So that's the bulk of our request, and we'd ask that you give us the funding for more people and the statutes that enhance our ability to investigate and prosecute so that we as a state can hold people accountable for these crimes. Thank you.
Thank you so much for your testimony. We do have the A5 amendment, and I wanted to ask the nonpartisan staff, Mr. Johnson, to walk us through the A5 amendments. Representative Norris moves the A5 amendment. Please help us understand what is in A5 amendment.
Mr. Chair, members, Ben Johnson with House Research. Senate room. Mr. Chair and members, Ben Johnson from House Research. I'm going to walk through the A5 amendment. This is a lengthy amendment, but it is a page and line amendment, so if I don't mention a section, it is staying the same as the underlying bill. The first section change that you'll see is Section 2. This is a technical change. This particular section of law was amended last session. There's no substantive change to the underlying bill. It just updates the existing statute to the 2025 version. Section 3 is the new provision that the Attorney General and Mr. Wonka just explained in detail. Briefly, the first subdivision identifies the various ways in which someone can now commit Medicaid fraud under this particular bill. It identifies 8 different potential scenarios that would qualify as the crime. Subdivision 2, which is on page 2, starting at line 29, establishes the penalties. It establishes a base penalty for a violation that would have a maximum prison sentence of 10 years. And then it has enhanced penalties. If the theft is over $100,000 but less than $1 million, the maximum period of imprisonment would become 20 years. And then in paragraph C at the top of page 3, if the theft involves over $1 million, the maximum period of imprisonment becomes 30 years. Subdivision 3 is a new penalty. This is a gross misdemeanor penalty for failing to keep or maintain records that you're required to keep under the other areas of law related to the human services. Those are in Chapter 256B and 245A. Subdivision 4 on page 3 identifies that this is a continuing offense. This is related to the statute of limitations. Typically, a statute of limitations begins to run once a crime has been completed. This just indicates that if there's a series of actions that constitute Medicaid fraud, you don't start from the first of those. The offense is considered continuing, and so the statute does not begin to run until those are all complete, or if it's ongoing, it has not yet begun to run. So this allows a longer look-back period for older offenses that may come to the attention of law enforcement or the Attorney General's office if there's an ongoing pattern of this conduct. Subdivision 5 is a venue provision. This just indicates that there are multiple places where this could be brought and charged depending on the underlying facts of the case. Subdivision 6, which is at page 3, line 22, creates a restitution provision. This is an expansion of the typical restitution authority in law. This would allow the collection of restitution for certain offenses that were committed but not necessarily charged as part of the underlying charges in the case. That's the end of the updates to the bulk of the section. The rest of the amendment is largely technical, so at a high level, you'll see a change to Section 5. This is similar to the earlier change. This particular section of law was amended last session. There's no substantive change to the underlying bill. It's just updated to reflect the 2025 version. The same thing is true of Section 6, which is on page 425. No substantive change to the underlying bill, just this particular section was amended last year. Finally, Mr. Chair, the change at page 6, line 9 is to the appropriation. The underlying bill had an appropriation of $390,750. This updates to reflect the numbers that the Attorney General referenced earlier, which would be $1,230,000. I've had some questions about the changes to the base. Just as a reminder, this is an appropriation in the second year of the biennium, which means this would be an ongoing appropriation and be in the base. Mr. Chair, that's all the walkthrough of the amendment.
Thank you so much, Mr. Johnson, for the explanation of the A5 amendment. Any member discussion on the A5? Seeing none, all those in favor, please say aye.
Aye.
Opposed? Abstentions? Hearing none, the A5 is now adopted. To your bill as amended, Representative Norris. Do you have any updates or you want to go to member discussion? Members, we have the bill before us as amended, and we will stick to the bill before us. So please, if you have any questions, make sure that it's based on the bill which is in front of us as amended. Representative Barker.
Thank you, members. First concern that I would have with this is we've seen, judges dismiss cases with fraud, okay? So how do we address that? I mean, this may come across a little edgy. It's nice here now saying, we're going to be the big bullies on the block, but if the judge dismisses it, what do we do?
Director Wong.
Sure. Well, presently, some of the cases that you reference are cases that are charged under theft statutes because, number one, that's what we have available to us now, right? And the reason some of the judges have dismissed that is because they have found that the theft statutes do not apply to the fraudulent conduct in these cases. The reasons for that are contained in this bill, right, that would cover that. You see falsely, you see, destroying records after a lawful request. We have cases that we charge where we believe services are not provided. We have some witnesses who say, I didn't get services. We have agencies that keep no records whatsoever, operate out of a mailbox, have no service records, and have destroyed them after we sought to seize them, right? We say that is theft by swindle. Judges have said, your theft by swindle statute doesn't cover that. So we have included a subdivision here that would codify that as medical assistance fraud and allow us to charge that case going forward. We have other instances here, for instance, presenting false information on provider enrollment documents. We have had judges who said that is a crime of theft by swindle. We've had judges who say that is not. There is now a specific subdivision here that says if you present false information on provider enrollment documentation with the intent to defraud the Medicaid program, you are guilty of medical assistance fraud. This should eliminate those rulings from judges that dismiss the cases. In the interim, we appeal those decisions. We are presently appealing one of them. There are others that we have appealed, and we will continue to do that because we do believe that the present laws cover this conduct, but we also recognize that there is a difference of opinion between judges in districts, as happens all the time for district court judges. And so we have chosen not only to appeal that for the current cases, but to write a law that will eliminate these problems in the future for our prosecutors and will allow us to prosecute what seems to be, to any outside observer, clear Medicaid fraud.
Follow-up? Thank you, Chair. Okay, thank you. So, and this is not a gotcha question, okay? But this is what I'm hearing out in the district, because these are taxpayers' dollars, okay? So why do we have a U.S. Attorney General office who has this amount of cases, and what it seems, again, I'm not here to poke your eye, but it's going to come across that way, the Minnesota Attorney General's office is way down in the basement with the amount of cases. This is what we're seeing. This is what I hear from the public. So how does this bill help that, or why do we have what seems like such a different amount of fraud cases that's being prosecuted, please?
Director Wong.
Or even addressed?
That might be a
Attorney
better question
General
for me.
Ellison.
Yeah, what I would submit to you, Representative, is that this is because certain high-profile cases have received quite a bit of attention, but we are prosecuting Medicaid fraud cases all the time in large numbers. That's just the reality. So if you ask me why does it seem this way? It seems this way because there have been some high-profile cases that are different from Medicaid fraud that have received a lot of immediate attention, as they should. And so it seems that way. But the fact is that our office is very busy and, in fact, needs more people to do the work that we're facing. And given the fact that the current United States Attorney's Office in Minnesota has seen a dramatic number of resignations, we certainly feel that where there is parallel jurisdiction, we really may have to take some of those cases. So that's the reality of it. You know, there are feelings and appearances, but the numbers suggest, or don't suggest, they show that our office is extremely busy and very highly effective. And in addition to that, we work with federal authorities all the time where it's appropriate to do so. So I hope that answers your question, but we'd be happy to respond to any follow-up.
Did you want to add anything, Director Wong?
No.
Okay, thank you. Thank you. Thank you, Chair. Thank you, Attorney General. So when you talk about the numbers, and again, we are here to work with you guys, because when we're in our district, we get the bulk, and it's not hugs and kisses, okay? Because these people work really hard for their taxpayers' dollars, and they're getting quite ticked off that, you know, we're seeing this. So when you say, well, we have high volume of numbers, and I would not disagree, there are some high profiles, but at the end of the day, it is our responsibility, your responsibility, to be a good steward of taxpayers' dollars, and our constituents are saying, that's a bunch of snert, and so forth. So, I mean, address that there, when you say, well, we're doing high volumes, define high volumes of cases being prosecuted, and then explain also, of course, how it seems that you're saying that this bill would help out because you're going to get more people, too. So if you could, one of you two could answer that.
Well, I'm going to leave the numbers
AGL,
issue. Thank you, Mr. Chairman. I'm going to let Mr. Walker deal with the numbers issue. What I will say is that if we all agree that we've got to protect taxpayer dollars, we've got to stop fraud and fight it, then what I'm telling you is that we have been, we are, and we will do more prosecutions. We've convicted over 300 people in the last several years, convicted them, not just charged them. We charged many more than that. And so the answer is not to oppose our bill. The answer is to support our bill so that we can do the prosecutions that your constituents and mine expect. So.
Director Wonka.
Yeah, and just to put a finer point on that, like I think I touched on, we were 6th in investigations per Medicaid expenditures in the entire country last year. We were 5th in fraud charges, and we were 8th in fraud convictions in the entire country. And we've been on average 5th in fraud convictions in the entire country over the last 6 years. In 2023, we had more convictions than all but 5 units, and 4 of them had much larger budgets than us. In 2024, we were 5th in the country in fraud charges. So this is not to say, and this is, keep in mind, this is in the Medicaid fraud space, right? Our federal regulations do not allow us to use Medicaid fraud, the Medicaid Fraud Control Unit, to investigate or prosecute fraud in other program areas. That's not something we can do. The feds will take back money from us if we do that. That's just the way that our grant works. That's the way that our federal regulations work. So when we limit this conversation to the Medicaid fraud space, which is what we're talking about, right? And you've undoubtedly heard about this, the housing cases that are being investigated by the U.S. Attorney's Office, the autism cases that are being investigated. Our investigators work with federal law enforcement authorities to investigate those cases. But when the United States Attorney's Office shows an interest in prosecuting it, that's great. They have much more expansive statutes than we do right now, and we're trying to correct that with the MAP Act here. They have much higher penalties than we do. We're also trying to correct that with the MAP Act here. And they can collect restitution in a more expansive way, which again is one of the reasons why it's here. So when they show an interest in prosecuting these cases, we want to help them. We devote our investigators who have specialized expertise in Medicaid to assist on those cases by helping them with search warrants, by helping them doing interviews in the field, by helping them with the data analysis. And then those cases are prosecuted and people are held accountable. And we do that because it's the right thing to do. But within our regulations, we are also required by federal law, whenever the United States Attorney's Office or federal law enforcement is conducting an investigation into a Medicaid provider, we are required to provide them with any information that we have in our case file and to assist them in that investigation. So that's what we're doing. And that's what we're doing as a state. And if that is not being publicly shared as much as it should, that's something that we can try to do a better job of messaging. But I hear you. I hear your constituents' anger at this. I think that everybody is upset, rightfully so, about the level of fraud. But we at the State Medicaid Fraud Control Unit and our people have been doing this work on the ground and have been getting very good results with the resources that we have for years.
Just final comment. Yeah, thank you. And I appreciate that. I think, I know we're focusing on the bill and we can go under different sidelines. At the end of the day, though, we have constituents, quite a few of them, who does not think that state government is doing its job. And I would invite you to do it because what our constituents are seeing is like, and I heard that from you, Attorney General Ellison, is, we've captured $80 million of fraud, okay, in Medicaid. I think that's what your statement is. That's like giving a child a bite of an apple and then running away and giving 5 gallons of ice cream and saying, I'm being a healthy parent. What our constituents are seeing is, well, how about all this? Now, you and I understand that you have certain jurisdiction, but you also have influence too. We all have jurisdictions in what we do, but we also have influence. So it's that perception that's really concerning because we see the Attorney General Office, U.S. seems to be doing more than what you're doing, and you gave an explanation on that. So that's my final comment, because I suspect other people have questions.
Mr. Chair, can I just respond briefly?
Attorney General Ellison.
Let me just say, this communication issue and perception issue, that's something that I think we should take on. I can say before this committee that I have no idea who Mr. Wonka voted for, what political party he's a part of, don't know, don't care. He is a hardcore prosecutor who prosecutes criminals on behalf of the state of Minnesota. So when it comes to, please don't make it his responsibility to communicate better with the public. I'll take that on. And all of us who have election certificates can do that. But let the prosecutors prosecute. And I just want to be clear if you hear what I'm trying to say. Yeah.
Representative Uganda.
Thank you, Mr. Chair. First of all, I would say I'm on record as supporting this, so I'm in full support of what's happening here. Inside of that, if you have a department that's running pretty nearly at capacity, you kind of do the work, do it well, but you can't maybe go above and beyond. So you're waiting for referrals, and I'm seeing the numbers of referrals going up. But if you get to where you have the capacity, I would think that, the people that you're working with, the fraudsters, the criminals that are there might be part of a network. You can start to dismantle that network, and you can start to go after some bigger fish. I feel, and then the better teeth to do the better prosecution and have it actually stick where they actually become sentenced and appropriately. And so we're giving you the teeth, we're giving you the staff, we're giving you the budget. Do you think you'll be able to go above and beyond and actually uncover more fraud, not just wait for the referrals?
If I may, Mr. Chairman. Well, certainly with the tools, if you all can help us get this bill through, I believe that will happen. But I do want to offer this very important caveat. So the way this system is set up is that there are people who work at the agency and they screen who gets in, who doesn't. We have zero to do with that. Then there's the ongoing monitor of people participating in the program. We don't have anything to do with that. Then people at the agency level think, okay, this doesn't look right. Then we get it, then we're on. We get there basically when the 911 call is made, just like the ordinary police and prosecutors. Now, how can I say yes to your question? Here's how. Because once Nick and his investigative team start digging into stuff, it's like, oh, wait a minute. This person showed up here and here and here. What's going on there? Now we're starting to unravel networks. And so I want to say, the answer to your question is yes, we can. Yes, we will. Yes, we will be able to do that much more effectively, but not necessarily through the normal channel. Thank you very much.
Thank you. Representative Murphy.
Thank you, Mr. Chair. Thank you. My question is really around, we have this need for holding wrongdoers accountable, and I appreciate that we're looking at some of those same things. My question is that we've had a lot of whistleblowers that have come forward. What is your record? What have we done in terms of the number of whistleblowers that have reported issues within the agency of the DHS, as far as disciplinary actions, how many? With regard to under investigation, how many? With regard to prosecutions, how many? You're looking for a lot of dollars, $800,000 to increase your activity. What's the activity been to date with regard to DHS, not including feeding our children?
Mr. Chairman.
A.J. Ellison.
Representative, we don't have anything to do with the operation of the agency. The agency, we're a separate entity set up by the Minnesota Constitution, and we operate in the role of prosecutor and investigator. So let me just say one more time, when people apply to be in the program, they deal with an agency. Then when they engage in the activity of the program, they're monitored by the agency. When there appears to the agency there to be criminal conduct, they refer to us. So to the degree that somebody, so the whistleblowers, look, if we believe somebody violated the whistleblower statute and we have authority to prosecute it, we certainly would, but that's just not our lane, if you understand what I'm trying to say. You know, our lane is, like, think of the show Law and Order. We're that. We work with the cops and the prosecutors. That's who we are. We don't run the agency. So, I mean, I don't know, do you want to add anything?
Director Wonkum.
Yes, I would just add, there's federal regulations that require us to be entirely separate from the agency that administers the Medicaid program. So if a tip comes to us and is directly reported to us by someone, that's going to go through our normal intake process that we do with any sort of law enforcement tip, formal referral. If there is a whistleblower who reports internally to other people at DHS, that is not automatically going to come to us. We're not even going to be aware of that. And we certainly don't have any sort of disciplinary authority or anything like that over DHS employees. Does that answer your question?
I just have a
Representative
follow-up.
Murphy.
Thank you. So if there is a whistleblower and it does come to the level of a criminal activity, when and who gets involved in? Are you involved if there's a criminal activity inside of DHS?
Mr. Chairman.
A.J. Ellison.
So, Representative, if, say, for example, hypothetically, there's some sort of criminal wrongdoing happening in the agency, and a whistleblower says that's wrong, and say theoretically, hypothetically, they call our office. What I would do with that is and it probably might come to somebody else other than me, but say it comes to me. Say, hey, boss, guess what happened? What I would do is I would contact the county attorney's office or the U.S. attorney's office or the FBI or the sheriff or the police. And the reason why is that representatives and senators in years gone by wrote the statutes of the state of Minnesota, which empower county attorneys to prosecute crime in the jurisdictions in which it happens. Let me be clear, and this is important, because I didn't know this when I got this job, so I don't expect people to just know it. But the only cases that we have original jurisdiction on, the only case that I don't need to talk to anybody to charge as a crime are Medicaid fraud cases. Every other kind of fraud case is the county attorney or the U.S. attorney. Now, Medicaid fraud is a specialized thing because we get a federal match, 1 to 3, and then there are clear program guidelines as to how we operate that program. So because what you're sharing, the situation you're sharing is a real situation, and I share your concern about it, we want whistleblowers to be protected and to come forward. But if this ever were to come my way, I'm going to be calling an investigative agency or the county attorney.
Representative Murphy.
So if we call the county attorney and there's a criminal activity in the DHS, so I come from agriculture. The barn door was left open. Cows got out. Rustlers stole the cows. Is the guy that left the barn door open have any responsibility? And if he did it on purpose, can the county sue that individual that the whistleblower brought forward?
A.J. Ellison, I know we're deviating from the discussion of the bill.
Thank you for your question. It's an important question. But it's a little out of my lane and what we're doing here. But just to answer your question, it would depend on whether it was negligently left open, deliberately left open. Maybe the guy was in on it and he said, hey, I'm gonna just leave the door open and you come back. Then that would be a crime and they would have to face responsibility, criminal liability. If it were a negligent act, maybe there would be civil liability for it. If it were an inadvertent act that there was no culpability for, just pure accident, not that, no one's fault, then maybe it wouldn't be charged. But it would depend upon what we call in the legal world mens rea, which is your mental state when you did what you did.
Just the last comment.
Representative Murphy.
So, thank you, Chair Noor. So just as a kind of a 30,000-foot view, though, the AG's office and the folks that we're talking about here, If there are people that are criminal, have done criminal activities and leaving the barn door open, that's not something you would be able to prosecute.
Attorney General Ellison or Director Wonk?
It would depend. I can't get, this is a very fact-specific question, right? What you're talking about is really either a conspiracy between DHS employees and providers who are stealing from the program, or it rises to a level of what we would call aiding and abetting under the law, where DHS, your agency employee, is aiding and abetting provider fraud. And what the law provides there is you have to prove beyond a reasonable doubt that the employee knew the crime was being committed and intentionally aided the crime. If there is evidence of that, and it is aiding and abetting provider fraud, that is theoretically something that could come within our jurisdiction. That's true at DHS, that's true for a managed care organization. But again, that is a very specific, fact-specific inquiry that would depend on what was uncovered in an investigation. Does that answer your question?
Yeah, thank you, Mr. Chair.
Thank you so much. We have Representative Knudsen.
Thank you, Chair. Thank you for being here today. Just have a couple questions. First, what is the most recent budget for the AG's office?
AG Ellison.
Yeah, you know, I came here to talk about Medicaid fraud. If I came here to talk about budget, I'm sure I'd have to the penny numbers, but just didn't. I came here to talk about this program and this bill, ma'am. I'm sorry.
Representative Knudsen.
Okay. Thank you, Chair. I'm sure we can probably find that.
Yeah, it'll be easy to find.
Yep. And how much of this budget goes toward the Medicaid fraud unit? Do you have a percentage, a ballpark?
Right.
AG
So
Ellison.
so we put up. The state of Minnesota provides a quarter of the Medicaid fraud budget for our Medicaid fraud control unit. So it is certainly a substantial amount of money, but it's relatively small compared to our overall budget.
Representative Knudsen.
Thank you, Chair. So the rest of that's a quarter, is the rest of that federal?
Yes.
AG Ellison. Representative Knudsen.
Thank you. Thank you, Chair. How many prosecutors do you currently have?
Director Wonk.
So we have 32 people on staff right now. There are 7 prosecutors, 17 investigators, and the remainder is legal support staff, legal assistants, paralegals.
Representative Knudsen.
Okay, thank you, Chair. So you have 7 prosecutors right now?
Yes.
So with this $800,000, how many more prosecutors are you going to be able to hire?
Yes,
Director Wonk.
this will be 3 prosecutors, 11 investigators, and 4 support staff. And the reason for that is right now our greatest need is for people who can get on the ground and go out and knock on doors of providers, ask questions of providers and recipients who we think are either not delivering services or not delivering what we want, who can review healthcare records, who can execute search warrants, do that data analysis to move this bulk of cases into the charging stage.
Representative Knudsen.
Thank you, Chair. Just one more real quick. So there is no room in your current budget to do this without more money.
AG Ellison.
So under statutory guidelines, we cannot just shuffle money around. This is a specific federal program that requires a match, that requires that we don't have people who are working in other parts of the organization coming over to the Medicaid control unit. And it's all, and not only does the grant require us to operate that way, the skill challenge does too. So for example, we have a group of criminal prosecutors at the AG's office who do general crime prosecution. But this particular unit requires you to know a lot about, first of all, the Medicaid statutes, and then also how to use complex white-collar fraud documents in your prosecution, how to investigate them, how to present them to a jury. It's just not something you can have somebody come from charities and just do. It would take them 6 months to be able to do the work. So we can't just so it's a very caverned off group. So, I don't know, Nick, do you want to elaborate?
Director Wong.
Yeah, so this funding source, right, our grant and the federal regulations surrounding it require anybody in the Medicaid fraud unit to spend 100% of their time working on investigation and prosecution of provider fraud or the abuse, neglect, and financial exploitation of vulnerable adults. We can't have somebody who, say, spends half of their time in another division and half of their time in the Medicaid fraud unit, because that's going to violate the federal funding requirements in what's called federal financial participation for the unit.
Thank you, Chair. And just final, I wasn't suggesting that you use people from other agencies or anything like that. I was suggesting that you find the funding from your already very large budget. So, thank you.
Vice Chair.
Thank you, Chair. Thank you, Representative Norris, for doing this work. I know that you have been really diligent in finding us good solutions across the board around this. My question comes from the penalties part of this. I know you guys mentioned that penalties are much higher if fraudsters participate in fraud against the private entities. The changes that we're making here, I know that in the amendment, they're on 229 to 3.5. With those changes, where are we in comparison to the private market penalties? Are we consistent? Would this be higher then? Could you explain that to us, please?
Director Wong.
Yes. The 20-year maximum for the over 100,000 is the equivalent with the current theft statutes. So right now, what you see in a theft statute, a theft by swindle statute, that's the maximum penalty. The 30-year penalty for over $1 million, that does not exist in the current theft statutes. That is in the Medicaid assistance fraud statute. That is a new level based on just exactly how much fraud we are seeing in the program. It is also being done because if you look back at the current theft statutes and the $100,000 limits, those were put into place in the late 80s. They have not been updated in amounts for over 40 years. And stealing $100,000 in the late 80s was a lot different than stealing $100,000 in 2026. So having a new statutory level for large dollar offenses against the Medicaid program is why that over $1 million penalty is in there.
Vice Chair.
Thanks, Chair. I'm really appreciating your deep answers. I think I just need a little bit more simplified answer. If I am a fraudster and I look at the penalties, is what we're changing making government penalties comparable to where the private industry penalties are? Or are the penalties that we still have with these changes for a fraudster coming to take money from the government, where are we in comparison to that?
Director Wong.
If you stole money from the Medicaid program, you would be punished now, under these changes. If you stole $150,000 from the Medicaid program, it would carry the same penalty as if you stole it from the private sector if you enact these amendments.
Thank you. Thanks, Chair.
Thank you so much. A.G. Ellison, closing remarks.
I just want to say thank you, members, for your kind attention to this issue. I would like to speak to everybody individually about the importance of supporting this bill. I want to thank all members. This is a good bill. It's an appropriate bill for the moment that we're in, and thank you for your kind attention.
Representative Norris, your final remarks.
Yeah, thank you, Chair Noor, and thanks to the committee for the discussion. I think this highlights the fact that there's not one silver bullet that's going to solve all of the fraud challenges that we're seeing in Minnesota. It's going to take multiple approaches, in part because there's lots of different players in the system, and each of them have a unique role to play. The Medicaid Fraud Control Unit has a critical role in that, and I think it's clear that there's a need to enhance the penalties, give them more tools in the toolbox, expand the definition of Medicaid fraud. And I'll just highlight for the members, since I think this is in your packet, kind of to the point of the effectiveness of this office. On the last page of the handout, these numbers are from the federal government. So they're, unbiased source from the federal government. You can kind of see the number of staff that our office has compared to similarly sized states in terms of Medicaid budget. And then it also notes that an audit from the federal government found that from 2020 to 2022, Minnesota won the most convictions for provider fraud when compared with similarly sized states. So despite having half to a third of the staff that a lot of these other similarly sized states have, we were able to win the most convictions compared to those states. So I think that's something Minnesotans can take confidence in, and by giving them more tools, we can do a better job of cracking down on this business model of fraud that we're seeing across Minnesota.
Thank you so much, Representative Norris. I know we have a few things that we wanted just to update, like the PCA mentioned. We wanted to add the new term that we have for the PCA, CFSS, just to make sure that it's more clarity. I don't know. We will do that in the next. It's just more of a technical as we move forward. With that, Representative Norris renews his motion that House File 2354 as amended to be re-referred to Judiciary, Finance, and Civil Law. All those in favor, please say aye.
Aye.
Opposed? The motion prevails, and the bill as amended is now re-referred to Judiciary, Finance, and Civil Law. Thank you so much, everyone.
Thank you.
The final bill is mine, so I will let Vice Secretary take on.
Yes.
Yes, thanks.
Okay, we have the last bill on the agenda today is House File 3634. Chair Noor, as you're getting set in, would you like to move your bill?
Yes, Madam Chair. I would like to move that House File 3634 to be laid over for possible inclusion.
Sounds good. Chair Noor, to your bill.
Thank you, Madam Chair and members. House File 3634 expands the use of electronic visit verification, or otherwise known as EVV. EVV is a federal required tool that electronically confirms that services billed to Medicaid assistance were actually delivered. It records basic information such as the type of service provided, the date, location, and the start and end time of the visit. This protects Minnesotans and ensures that taxpayer dollars are used appropriately where needed. Minnesota already uses EVV for certain services such as PCA, CFSS, home health services, IHS, and various programs. I know we're getting there. Some of it right now, it's about 80% or so. Hopefully we can reach that target of 100% in all those programs. This bill expands EVV requirement to include services delivered by providers or within programs designed as high risk, consistent with federal risk classification. It allows the commissioner to apply EVV to additional services as needed. Let me say this bill does not change eligibility for services or reduce access to care. It simply strengthens verification to ensure services billed were actually delivered. And this is not to intend that this bill will be required to be used in every instance whereby it does not apply, such as in a group home setting, CRS, or other instances whereby it's a daily rate. It doesn't help us to track everything in those instances, but we will let the agency make the right decision where necessary. So this is about accountability and ensuring consistency and making sure that we do have the right documentation using the tools that we have. With that, members, I would like to allow the testifiers who registered to come and testify on this bill.
We have two testifiers. If you want to join at the table, we'll start with Ellie Skelton. If you want to start introducing yourself to the committee and begin with your testify.
Chair Noor and representatives of the committee. My name is Ellie Skelton. I'm the Executive Director of Touchstone Mental Health. Touchstone serves more than 2,000 people across Hennepin, Dakota, and Anoka County. 98% of the people we serve are below the poverty level, have serious mental illness, substance use disorder, and often a history of homelessness. We provide several of the designated programs as high risk, including the critical services of ICS, ARMS, and IRTS. Sorry for the acronyms. Community providers are already under extraordinary administrative and financial strain. Fraudsters always find a way around the rules. We don't. We take these very, very seriously, and we go through, and every additional thing that you add, we do. And it does get in the way of care. These are low-margin services. We believe strongly that significant steps must be taken to prevent fraud, and we want to make sure that the new measures put in place target program integrity rather than adding administrative mandates. Every additional mandate has real consequences. We need more licensing staff. We need licensing staff that come out and visit the IRTS programs. We do daily summaries, rehabs, diagnostic assessments. It's one of the high-risk services, so the way that it's written, it's saying that EVV would be mandated in IRTS. I don't think we should mandate all high-risk services do EVV. Leave it up to the commissioners. Is EVV in the current services that are using it actually improving outcomes and reducing fraud? Can we look at where EVV is being used? Is it interfering with access to services? It could be. I would like to get more input from home care providers in rural areas that are talking about cell phone coverage in rural areas, not allowing EVV, and then your billing doesn't go through if the EVV isn't attached to that visit. Doesn't mean the visit didn't occur. You know, we don't have great cell phone coverage everywhere. So I do think we should look at what EVV is currently doing before we mandate it at other high-risk services. We want program integrity. We want every dollar to be spent to well-meaning service providers that are doing a good job every day. Let's see, strengthening licensing capacity. So when I've seen rapid growth in services and we don't have the corresponding fiscal note for DHS to have licensing staff, that's where things have gotten way out of control. Housing stabilization, how many providers got added so rapidly and we didn't have the staff for the oversight? Providers, licensing staff coming out, there's only like 84 IRTS providers in the state, and maybe 2,000, 2,500 Minnesotans receive that service every year. If you're out every year to visit those programs, both to make sure that they're following the highly regulated service and providing technical assistance and support, we're going to have a good, robust service. Doing some kind of EVV in a residential setting doesn't make any sense. I also have concerns about some of the other settings, ARMS. We do it in both group and individual settings. I think that might be problematic as well, but thank you for the opportunity to testify.
Thank you, Ms. Skelton. Josh Berg, go ahead, introduce yourself for the record and begin.
Thank you, Madam Chair and members of the committee, and thank you for the opportunity to speak to you this morning. For the record, my name is Josh Berg, and I'm the Director of Minnesota Services and Strategic Growth at Accessible Space, Inc. First, a simple truth, and I think something obvious to all of us in this room, that Minnesota's Medicaid services are not all built the same, and EVV was never designed to apply universally. Some services, like PCA or CFSS, are billed in 15-minute units and are federally defined personal care. For them, EVV fits. But for the vast majority of HCBS services that do not, do not function this way. ICS, Adult Day, ACT, IRTS, recuperative care are daily rate or per diem models built for continuous or intermittent support that doesn't begin and end like a visit. ICS in particular, and what I can speak to directly, operates under DWRS, not a time-based billing, because it was created to support people across the natural flow of the day. This is especially true where staff are on site 24/7, 365, meeting the needs for these individuals throughout their lives. There is no arrival or departure time, so there's no discrete visit to verify. Forcing EVV onto ICS would produce artificial, inaccurate data that misrepresents what's actually happening. And the deeper issue is misalignment. If you ask 10 people, heck, ask 10 people from DHS what ICS is supposed to be, you'll likely get 10 different answers. If you go back to the DHS-led work groups and the original waiver plan amendments, the ICS we designed back then together is not what ICS is being interpreted and enforced by today by OIG. That confusion is hurting providers, counties, and most importantly, the people we serve. So let me correct the record too. ICS is not an unregulated space. Providers already meet robust documentation and oversight under Minnesota statutes 245A, 245D, 256B, and this includes incident reporting and staffing standards to person-centered planning and service documentation. ICS is an intensive support service licensed under 245D. EVV doesn't add integrity to ICS. It overlays an incompatible time clock onto the per diem model. Meanwhile, we're dealing with shifting definitions, rapid interpretation, misaligned funding, and a strained housing market. And EVV expansion is presented as if it solves any of that. It doesn't. This is precisely why ICS must be codified in statute, and that work needs to begin now. We already have language, and providers like ASI and Touchstone are ready to do the work. And a huge thanks to DHS that as they have committed to an ICS-specific meeting tomorrow, a step we welcome and appreciate so very much. But one meeting will not fix years of misalignment. We need ongoing structured collaboration with clear timelines, iterative drafts, and accountability so ICS is aligned to its actual practice. But I digress. I also want to address the last line, 2.12 of this proposal, that would give the department unfettered authority to require EVV or similar tools whenever the commissioner believes it's appropriate. With respect, that directly contradicts what many members of this committee have emphasized over the past few weeks, the need for clear statutory guardrails, transparency, and stakeholder involvement. Handing sweeping discretion to the department after years of volatility invites policy by reinterpretation instead of policy by legislation. It would widen the very uncertainty you've all insisted we reduce. If the goal is program integrity and consistency, the path is clear statutory language, not open-ended authority. Assuming this will be laid over, I'm just asking that we continue to work on this language across all the impacted service areas and convene a broad solutions-focused process that includes providers, participants, advocates, counties, and DHS to work together on whether and where expanding EVV would actually improve outcomes. Let's take the time to develop shared understanding, define the real problems we're trying to solve, and create statutory language that's effective, practical, and supported by the people who will live with it. Because while frameworks are debated, people are losing access to the supports that keep them safe, stable, and housed. This is shaping lives every single day. Please help stop the damage, refocus the work, and put the emphasis back to where it belongs, on the people who rely on these services to live the lives they choose. Thank you.
Thank you, Mr. Berg. Always appreciate your insight and suggestions you provide for the committee. Anybody from the public wish to testify on this bill? Don't all rush up at one time. Okay, seeing none. Members, any discussion? Vice Chair Gilman.
Thank you so much, Chair. I don't know who we should ask the question to here, but just, I did do a lot of discussions with providers and folks. A lot of people are already using EVV. They do like it. They like for their businesses to have the records, things like that. And again, we've seen a lot of things, not only on the news and just the reporting that's been happening and hearing quite a bit through the fraud committee with the not having transparency and just seeing that there was a lot of Medicaid billing and fraud happening in this avenue. So I like that we are looking at some solutions. So I heard you talk about some documentation that already exists in ICS already today for service deliveries, but what other accountability or documentation do you have in store? Because some providers would say, you know, they'd even look at if a provider was going to service someone and they wrote the wrong miles in. I mean, just they were, you know, and they'd have to just go through and ensure. And so that's why they chose EVV for their company, and it's just transformed them, and it's just all documented right in there. What else exists, or what could we do? That's my question.
Chair Noor.
I think that is for Mr. Berg.
Mr. Berg.
Yeah, Madam Chair and Representative, thank you for the question. And I can speak mostly to ICS because that's the world I live in. And that, you know, we have the 245D requirements that DHS can already enforce through licensing visits, which they do, and they check and they come and they make sure that we're documenting the services as they are to be delivered per the CSSP, the support plan, and what's authorized by the case manager and the counties. And so, we have, at ASI, we're fortunate, we have the electronic health record system that we utilize as well, where staff are documenting on a regular basis as services are delivered, as services are declined, and then what steps are taken in follow-up to those declination of services, which is an important piece to some of the other discussions we'll have. And I think the key thing to remember is DHS already has a lot of authority and ability to hold us all accountable for this. I think the legislative auditor yesterday said it very nicely at the seminar that I was at in the afternoon. We just have to allow or expect the department to do what is already in their authority to do, and we don't need to layer on anything until we can get to that standard and to get to that bar. And I think it isn't adding new things, it's doing the things that are already in statute. We've had perm audits, we've had requests for documentation to verify that the claims submitted matched what services were actually delivered. That's already there. They can do that, they have done it. I think it's making sure that we look at those existing statutory requirements in 245D, A, 256, and we can expand or help with those.
Thank you. Representative Kern.
Thank you, Chair. And my question is to Chair Noor. As we're sort of hearing the perspective from different providers, different service types, I'm glad to see, and we've talked about this behind the scenes, I think many of us, glad to see it's being laid over so we can continue the conversation. But I just wanted to give you the chance to offer your response or assurances that this work will continue, acknowledging sort of the unique situations that have been described today.
Chair Noor.
Representative Kern, Madam Chair, I think that is the normal process. We introduce the bill, we start having conversation. There's a lot of work that needs to be done immediately. So we don't have much time, but I've been getting a lot of feedback, and we'll be looking through every feedback that we're getting. But some instances, I think the best opportunity that we have based on corrective actions that we're required to do, we have to look at everything that is possible to make sure that the state of Minnesota does not lose federal funds.
Rep. Kern. Any other discussion? Seeing none. Chair Noor, final comments on your bill?
Thank you so much. Thank you, Madam Chair and members. I think this is a good start. We have put, front-end ways to protect taxpayers' money and also to protect the services that individuals are getting. What I'm worried about right now is the deference of almost $1 billion from the state of Minnesota. That happened yesterday. That came from the federal government sanctioning the state of Minnesota. This will be a disservice to the residents of the state of Minnesota. Whether you're in a nursing home, a group home, someone with disability, a child who needs services, $1 billion is not something that the governor can just spend. It's our responsibility. I would like to invite CMS and anybody who wants to work with us to solve those issues, come up with clear guidance that we can protect the services for the most vulnerable, those who need the most. Collective punishment is not the answer to a problem that we're facing right now. It requires a deliberate process that makes sure that we have good guardrails, we have good safeguards, we're protecting also those who need the most. People will die if we don't provide those services. People will go to hospital and spend more money. Others will go to a nursing home and other facilities. We're moving and shifting in that process. It's our duty to protect the services that Minnesotans receive. And as we do this work, I would like to invite CMS right now to come to join us right here so we can resolve those issues. It's not only the governor that is going to solve the problems. Legislature has got a role. And let's do our work and take care of the residents of the state of Minnesota. With that, I would like to renew my motion, House File 36, 34, to be laid over as possible inclusion in omnibus bill. And we will have further discussion. Thank you, Madam Chair.
Thank you, Chair. With that, we will be back on Tuesday. We get to be back at 8:15 on Tuesday morning. With that, committee is adjourned.